Hello, everyone, and welcome to the eighth module of the IAB Thoracoscopy certification course. Can't believe that this started off as a small idea, and now we are on the eighth module today. And I'm sure you guys have enjoyed rest of the other modules up till now. I myself, Dr. Mehul Thakkar, Treasurer of IAB, am proud to announce this webinar on thoracoscopy in out-of-box conditions. Now, out of box conditions are something which as beginners probably will not be touching, but as you grow into your field, you would want to know what else can you do. You can explore more with your thoracoscope. And for such a vast topic, we have a very star-studded panel with us today and two very stalwart speakers. And who better to moderate this and captain the ship other than our very own Dr. Amita Nene. Ma'am actually needs no introduction. We can just call her the Wonder Woman of bronchology or maybe pulmonology, and that would be enough. But she is the head of Department of Respiratory Medicine at Bombay Hospital in Mumbai. And she has been awarded as Legend in Pulmonology by the Health Minister in July 2023. And she has more than 50 publications, and she is the face of IAB currently, handling this webinar series and probably much more in the future. Without further ado, ma'am, I hand over the stage to you.
Thank you, dear Mehul, for such a kind introduction. I want everybody to know that Dr. Mehul, who is our treasurer, he loves to keep a low profile, but he's a thoracoscopy man of Bombay. He does more thoracoscopies than all of us do put together. All the module, all the questions, he has been kind enough to make every question that all the various moderators have been asking you all till date. So our Dr. Mehul is our wonder man, who is really a very, very modest and humble guy. And Mehul, thank you so much for making our dream of thoracoscopy webinar really into a great reality. Without your support, this would have never been possible.
Thank you. Thank you.
Yeah. So with this, we'd like to start our webinar. I basically feel that as Dr. Mehul told us, we really have a star-studded faculty today. And we have somebody who's very, very special, who's going to start today's innings. We have none other than the Emperor of Interventional Pulmonology of India. We have Dr. Ravi Mehta, who's going to be starting the first talk. Again, Dr. Ravi Mehta definitely requires no introduction at all, but just as formality, he's head of Integrated Pulmonology Service, Apollo Hospitals, Bangalore. He's an adjunct professor, Apollo Health Educational and Research Foundation. He's American board certified in 5 specialties: pulmonary medicine, interventional pulmonology, critical care, sleep disorders, and internal medicine. And there are just so many things to really talk about, but he's got more than 90 articles, reviews, abstracts, etc. So over to you, Ravi. We are waiting to go into a roller coaster ride, into a world of dreams that you're going to show us. Over to you. Welcome.
Well, thank you so much for a lovely introduction, and thank you for the invite. Kudos to this amazing, highly successful, giving us a chance to also do out of the box stuff. So without further delay, let me see if I can just share my slides. We will get started. Question visible? Is it visible?
Not yet. We are not able to see so far. I think your signal is poor, is it? Okay. We can see it. We can see it.
Yeah. It is visible now.
Wonderful.
Okay,
Okay,
fine,
there's some
sure.
good news in
Okay,
the
so
chat
the
box.
topic,
We already have 1,645 logins already, and the program has just started. Wonderful. Yeah, over to you, Ravi.
okay, lovely. So again, with thanks, we started this extremely interesting topic. So the we gave was slightly out of the box in terms of its title itself. So and let's see if we can justify what
Dr. Ravi's bandwidth, I think, is less, ma'am.
Yes, I think even we are not able to hear him.
Uh,
Shall we
it's
sort out?
not
Should we do Dr. Nitin's talk in that case? Dr. Ravi? I think he'll join in again.
Yeah. Wait for a minute whether we can get him.
Yeah, I think he's probably trying to log in again. Yeah.
Mine is a recorded talk, so in any case you can play it anytime. He's online.
Okay, lost everybody. I'm back.
Yes, great.
I'm so sorry. Okay, we start the whole thing all over again. Takes away the thunder, but why not? Okay, let's see. Okay, can you hear and see me now?
Yes,
Yes,
wonderfully.
Okay, my sincere apologies, and I will apologize on the on part of ACT or whatever is my internet. Okay, so back to the topic, the background in today's agenda, and let's go through history and people like Nitin and me who've been around a long time. Nitin, you longer. Let me rub it in. Basically, we'll always talk of this in context. Medical thoracoscopy in India picked up in the last 2 to 3 decades. I was going to say two, but I remembered Nitin. And some of us were the first entrants who got the field going. And then ultimately, as challenges, time, experience, and data picks up, we can question conventional wisdom and say, can more be done? Can we move faster, innovate, and go beyond what is there in literature, mostly Western? And not only that, do that responsibly, safely, and economically for the good of our patients. And then we look at a background that we've done this for interventional bronchology and also published it. And, personally, I've been given orations, also awarded orations, which I've been fortunate enough to give. And then we shift the whole focus to pleura. And today is such a story, the story of breaking the glass ceiling in the pleural area. And as Amita said, we proceed on this roller coaster with full steam. So my disclaimer is those who are accomplished, bear with me. Those who are in the field, starting in the field, just digest what is going on, and then we'll try and make sure that this is meaningful, fun, and at the same time makes it a little exciting and sets your mind and stage for what is to be expected in the future. So next generation thoracoscopy, which is today's agenda, and this is a good deal of the topics out there, and let's see what we can cover in the time we have. But areas which were traditionally not done, talked about, recommended, endorsed, or for that matter, taught in courses in the times we train. So many of these areas, as you can see here, and we'll be going through as much as is possible in the current time. So what do we have for guidelines? And British thoracic guidelines are often talked about when it comes to pleural disease. The good part is they're comprehensive. The interesting part is that they are often quite conservative, especially when it comes to the fact that this is a wide open playing field. And largely because it's been a surgical arena. We entered as physicians, and to give us a easy pathway at the same time, not antagonize our surgical colleagues, they called it medical thoracoscopy. So there's a reason it was called, and the BTS guideline often reflects that. Now, what do these guidelines say? You can do all the simple stuff, as is mentioned here. What they don't want us to do is what was traditionally complex surgical territory, or to put it simply in medical lingo, which is talked about, is if you can't deal with the complication of a procedure, don't do it. So that's where most of this other stuff was kept away from us. But over time, invariably we will impinge on other areas as our skills and our knowledge picks up. And so there came a gap. And today's discussion is there a gap we can fill? And let's talk about it. So transgressing conventional indications, the first one is visceral pleural biopsy. So when I trained years ago, it was very clear, don't meddle with the visceral pleura. Air leaks will be there. And if you can't fix something, don't do it. One of my old teachers, whose Dave was a big name in bronchology, editor, I think, of JOB, had told me he doesn't do enough pleura because he feels that the surgeons can do it better. But however, Europe, who always published, and Nitin will be slightly smirking because he must have done this before others too. Europe used electrocautery and tried to do a lot of stuff for two entities, aerostasis and hemostasis, air leak and bleeding, the two dreaded complications of any procedure. Now, what did we do as the learning curve went up and a good number of cases have been done over the 16 to 17 years we've been doing all this? A case will justify a lot of what we are discussing. This 47-year-old with risk factors of diabetes develops a problem in the pleura as mentioned, with the pleural tap not helping us. We go ahead with the pleuroscopy and here is what we find. So you can see the images here. The parietal pleura was clean, take my word for it, but the visceral pleura is studded with lesions. Hunting here and there, couldn't find anything in the parietal pleura. So we go ahead and cautiously, with a moving lung and using a certain amount of dexterity, skill, and assistant cooperation, take off material off the parietal pleura, which turned out to, as you can see, the experienced side does not need much of teaching over there. Granulomatous tuberculosis was the diagnosis. The question that comes up is the risk. Literature says 4 to 14%. Fortunately, I think most of us are able to break that risk with both skills and other strategies. And sometimes, as a small innovation, we take a small tissue patch from the parietal pleura and put it on there so as to try and keep any air leak in check, just like the surgeons do when they're in the OT. And this has stood us in good stead when it comes to doing a successful and safe procedure. And that is why visceral pleural biopsy in the right situation has significant diagnostic uh, value addition. And what do the guidelines say? The BTS guys said by and large, okay, they reluctantly admit, do it, but that's why they call it a level higher. So they've called it as level 2 thoracoscopy, and they put all sorts of fancy words which are like experienced or more experienced. I don't know, Nitin, are you more experienced and am I less experienced? And so this is the definition they gave over there. What we will leave as a take home message is don't do it as a routine thing. When there's no parietal lesions, you can do it. We use this patch technique and people will use cautery also. And the last call is yours when it comes to the fact that can you do it safely? Do you have the skills? It's a moving target. And does your patient, your infrastructure, and your assistant support such a venture with all the right intentions? Shifting gears now, what else can we do in pleuroscopy or medical thoracoscopy? So it used to be single port, but now suppose you have to do some work more or you have difficult access, double port with conscious sedation is very much a viable entity. Again, not talked about a lot. And the usual indications for this is not the run-of-the-mill free-flowing pleural effusion, but only if there is adhesions which require different access and so on. And so that's when you can often put a second port. Some people like to do it for pleurodesis also. And sometimes we'll have planned some more complex stuff, but these are the two general indications. That's where you can think of two-port pleuroscopy. Now let's shift gears into more out of the box or innovative aspects. What about looking at the fact that sometimes the patients in a position that they are in the intensive care unit, extremely sick, but you decide that there is a certain indication, value addition, and diagnostic or treatment advantage to doing a pleuroscopy. Let's see the case over here. 56-year-old female. You can see how bad her ILD is over there. Acute exacerbation, bulle out there, the honeycombing part which is there plus more. And now you have left with a pneumothorax and an air leak. Problem because of the air leak, the lung is constantly the leak is quite high. One chest tube is unable to manage, and often they had a positional issue where they were unable to guide the chest tube into the right area. So then it comes down to the fact that she is actually getting worse because of a pleural issue in addition to a parenchymal issue. And is it possible that if we get the lung to expand and the two pleural surfaces to approximate, can we seal the leak? So is that possible? So what we decided, and again, these things developed more in times when we could not shift, and COVID was a major one. We basically went and said, okay, let's do a bedside pleuroscopy. It'll help to find out what's going on. Sometimes helps to localize a leak, but that's another big issue. But at least it will help to guide your chest tube in the right place and at the same, which allows good expansion. So here you can see ICU pleuroscopy going on, and you can see some pretty bad lungs over there. And then under guidance, the chest tube was put. and we often will combine it with the pigtail so as to try and have a long-term strategy. That's a different story, and I can get into it later. But this helped the lung to expand, and conservative therapy helped her lungs to heal. And you can imagine that when there's HFNC, NIV-like strategies, this works out very well. And this gave her life back. Otherwise, as you can imagine, intubation or all the other options which go up, that would have been very, very problematic. So this helped us a lot. And the literature has been marginally supportive. Not a lot of papers mentioning this, but they did it under conscious sedation. And the idea was to try and avoid intubation as much as possible. Sometimes you have to do it in intubated people, but you need a very tangible endpoint, as was delineated by us. And you can see how complex it can be. First of all, you need an ICU with a decent space. And then you have to shift everything there. You can see how we're managing with monitors and all, and how you have to be a little uncomfortable because the bed is not the bed of your choice, but it can be done in the right situation. So take home points, indication must be strong. The surgical options must be not be there by and large, or this can also go on patient preference or economics. We can't shift the patient. Infrastructure must be shiftable to the ICU, and needless to say, skills and experience must be present to pull it off. What about more aspects of intervention healthcare delivery, which is again a different part of thoracoscopy? How can we shorten their stay? Can we do it as daycare? Can we avoid admission? And can that will translate into satisfaction, economics, and so many other good endpoints? That means do the procedure, expand the lung, remove the chest tube, and do all of that in a daycare model with all these endpoints being met. And so papers have come on this. People have looked at it. The West is pretty good at trying to do this and shifting the curve to a smaller stay. And in this paper, there was quite a lot of success and safety in trying to do daycare thoracoscopy. And our Coimbatore people also, Arjun, who likes to do plural work, has also put out an abstract in chest where he mentions their results with daycare thoracoscopy. We've also been doing it, but it's interesting to note that in India, often insurance companies wind up guiding it. But in patients who are geared up towards it, and I have to use this word, going out of pocket, often we can do it as a value-added proposition. Shifting gears. Now let's go to tech and tools in the pleura. We've talked of several aspects. Now we're going towards more fancy stuff. Can the instruments used in bronchology also be used in the pleural space? Well, people like Nitin who do rigid will say, yeah, we've done it for a long time. But the semi-rigid space, which is where most of the pleuroscopic practitioners are placed, it's not talked about a lot. And that's why, except for the forceps and maybe a cryo, which we'll touch on, not many instruments have been used, especially hot therapy with the semi-rigid scope. So now let's look at an application. A case where a 52-year-old had dyspnea, a left massive pleural effusion, and you can see that there is plenty of problems in this person's lung, loculated, lumpy, bumpy. At the same time, there's a free-flowing component in the end. So with the regular workup being non-diagnostic, we proceeded to a thoracoscopy or semi-rigid with the conscious sedation. And there you can see that we ran into adhesions as was expected based on the CT review. We also saw significant pathology. So here you can see this is also both visceral pleura and diaphragm showed pathology. And at the same time, there was infection because of recurrent taps, most likely. So in addition to the regular biopsy, which you've gone through in several lovely webinars, you can see here, now I want to just hold it here. See what's happening out here. The pleuroscope is held by the operator, and at the point the forceps is going in, I'll pause here. He's touching the forceps touching the cautery to the forceps, which is going through the working channel. And here you can see the coagulation effect. So you would think this is actually absolutely blasphemy that this is going to burn the channel. Turns out it's very safe. It's nothing different from Nitin actually using the rigid forceps and putting the cautery in the bag, but has not been talked about or discussed in semi-rigid. So this out of the box innovation was extremely interesting, and it basically can take this tool via semi-rigid scopy for effective use. So if this has been understood, and in a webinar, you're always shaky because you don't know about the audience, but I think this has been effective mostly, then you can achieve cautery over here and break these adhesions, which before used to be prohibitive because they're so-called vascular and you can't touch them. So this has been an interesting application of electrocautery in the pleura. Advantage again is, as I said, these adhesions which are prohibitive. You can tackle bleeds with that also. And it's extremely surgical in its principle, exactly how the surgeons handle their instruments. And it's similar to rigid thoracoscopy, but taken to the more used semi-rigid tool. Now, how about the same cautery in other areas? In this case, where we had to go in for a right effusion and atypical cells to define further, we found a large lesion there and see what's going on here. An inspection going on, a large lesion, and then it comes down to should we try and take more tissue? And not that I espouse we need to do it every time, but a thought came that can we snare this? So electrocautery snare was used over there to try and get larger pieces. So I'll admit to you that even the regular forceps will get it, but it helped us to use this instrument more effectively to get appropriate sampling. And the same thing, APC in pleura. In this gentleman who had carcinoid of intestine, we saw a right pleural effusion and we tried to take a biopsy over there. And you can see there was a ooze. The ooze started to well up. And then immediately a sterile APC fiber was taken and deployed over there to try and arrest the ooze because you're uncomfortable coming out when there is a welling up ooze. Of course, the first thing is always observation. But after that, if you think it's going to go on and it's going to lead to problems, and because this was carcinoid, we were scared, we were worried that this would not be an easy one. So APC was used effectively in the pleura. So another case where we can show you the similar principles. You can see a hemorrhagic effusion over there, lesions galore, vascularity will be there. But funnily, in the pleura, we're less afraid about vascular lesions because often if you do it against the rib and use tools, you can control it. The ooze started, which was a little concerning, doesn't happen often. And APC was used effectively to try and control it. And here is where more talc-fluorodesis was done. Another tool in the pleura is a pleural cryobiopsy in attempt to get more tissue, and especially if the pleura is serous. And this has also been talked about in Western literature. And it's also been published by our colleagues in Narayana who put an interesting paper of cryobiopsy of pleura for the right indications, especially in serous pleura. You guys can still hear me, right?
Yes, Dr. Mehta.
Okay, so now let's shift towards innovations. So if this description was not out of the box or innovative, we have more things which we can talk about in the pleural space. Pleurodiscs, and this has been a complete session, so I'll not talk about it. You know that it's done for malignant and spontaneous pneumothorax in the right situation, and the agents have been talked about in prior webinars. Most common are these two in bold and underlined. And so the question came up that in case we want to increase the yield, what is possible? The ERS task force recently talked about thoracoscopic pleurodiscs and mentioned that probably even if in some hands the success rate is similar between chest tube and thoracoscopy, the thoracoscopy component adds all these advantages: cost, hospitalization, and they claim lower recurrence, which we also substantiate in our 16 years of doing this stuff. We thought, why not add two agents to enhance the results of pleurodiscs? Normally, it's been done by one agent with the average success rate of 90%. But if we use two, and we use the principle of combined medicines, for example, acting, we have asthma therapy, COPD therapy, anti-inflammatory therapy. So why not if two inflammatory agents, such as talc, which works by this mechanism, and betadine, published by our colleagues and friends, Dr. Ritesh Agrawal and team, if they can be synergistic, symbiotic, incremental, or complementary, maybe we can breach the barriers when it comes to getting a success rate which is higher. So in this young male who basically had a second episode of spontaneous pneumothorax, and there was no clear indication for bleb stapling or VATS, we went ahead and offered him a fluoroscopic fluorodesis, and which he readily agreed to because obviously surgery is more scary for most people. And we went ahead and did that over here. And of course, inspection showed no blebs over there. So we were quite okay to go ahead. And after that, we started to put lidocaine on the parietal pleura. So this is a mini innovation, which some of you may notice, where we put an epidural catheter, which has a three-pronged lidocaine spray, so that it goes and actually sprays much more than just trying to push it through a syringe. And then we did betadine followed by talc. So first betadine was sprayed on the pleura, and then talc was also sprayed after that. So this was two-agent fluorodesis to give a better response and higher level of pleural anesthesia using the epidural catheter with which we push lidocaine. And these are easily available. We just get them from the anesthetist cupboard. And so this we've studied for quite a while now. For the last decade or so, in the 200 plus patients we've done, our success rate for malignant effusions has been 96%, and benign also has matched that rate. So this has been a remarkable tool in our hands with efficacy, safety, and ease demonstrated. Needs to go to publication, and abstract has already been put out. Now we shift gears and go to more complex innovations. I think I have my 7, 8 minutes more, guys. Or how much time?
Yeah, please go ahead. Go ahead.
Okay, so now let's look at prolonged air leak. So sometimes to look at both sides is useful, and we talk of cases, and I'll probably confuse you at the same time as I try to show this stuff. But bear with me as I walk you through this. We have a sputum positive male with left pneumothorax requiring chest tube, but as he's getting his management done, he gets a MI, and then fortunately no angioplasty done, at least, because stents create a nightmare, and he bubbles away for 17 days. And so that's a problem. And then we have to figure out what to do. Here you can see the pneumothorax, which is there, and it's a large one with significant problems. So the question was that, can we do something beyond surgery? He's not a great surgical candidate, as you can see, fresh MI and a low EF, not to mention, of course, the usual monetary issues. So can we do something which is interventional in technique, but which may work for him? We changed gears and we did what's called a triage fluoroscopy there to figure out. And here you can see the old chest tube, and lo and behold, the lower lobe you could see nicely bubbling away, large size, crater-like leak area. Obviously, this was the reason he was not settling, not to mention tuberculosis, which will not allow healing to happen. Options, leave him alone, but he's with us because he doesn't want to be left alone anymore. More chest tubes may not help, and can we use blockers? And we've described this blocker, which may be useful in his condition. And you can see the publication, which some of you may know, we've already put out in literature with our 15-year experience. So this blocker, which we call the customized endobronchial silicone blocker, can be used endobronchially in the segment we saw leading to that hole in the pleura, which may allow airflow to stop, healing to happen, and do the job. So in this situation, we went ahead. This is the bronchoscopy done. It's rigid, by the way. The blockers are made by us, so we call them customized, and they're made of the silicone stents by refashioning them. Some of you may be aware of them. And this is, we go into that particular segment we identified on the fluoroscopy and go and block it off. So this is what was done. And then, of course, we put little glue out there to make sure the blocker doesn't migrate. So after endobronchial appropriate sealing of the segment defined on the pleura, we went ahead, and this was more an academic thing, I think, to see what's going on. And you can see that widely leaking area had stopped, with a lot of with success being revealed in that. Fortunately, here collateral circulation was not a lot. And this was something we confirmed by putting saline also, that the leak has stopped, or if nothing else, remarkably reduced. The lungs expanded nicely, and then after that, the chest tube was removed, and pleurodesis was done because this is a secondary damaged lung with pneumothorax, and there was no recurrence. And 6 weeks later, we go and remove the blocker. So we got more fancy. Maybe our personal little peeve over there. We call this procedure bronchopleuroscopy whenever we had to do this. a little strange, but nevertheless sets the stage for what we are talking about. A similar age lady came also at that time, but had gone to the surgeon for a leak. They started to do VATS. She leaked horribly and desaturated. They abandoned VATS and said, "Can you do something?" We went in and with the fluoroscope and saw that there was an active leak over there in an area which was, there was a tuberculous pathology and an active leak going on, bubbling fast. So the conservative management, unfortunately, was not working and is unlikely to work. So we did the same thing, the CESB, we went ahead and put a blocker, and I will not go through the video at length, but I'll just reiterate that very quickly. The blocker placed in the upper lobe, the area which was identified, and the segment was sealed. And then when we go ahead on the other side, we could see that the leak had stopped, and that worked very well. At that time, we were also a little more adventurous, and it can be called as thinking which came on the spot actually was different. We actually put glue on it also. So we have Tissile glue, and Nitin may have used this also, which can be used through the fluoroscope to on this area to further try and make sure it doesn't leak. So this was an add-on thing, elective, but it was done so that we don't have to take up again, especially since she had gone through a failed VATS. And she improved. This is a success story where you can see that this is the leak and then the lung expands, and thanks to both the interventional care and tuberculosis therapy, she became much better and the problem was solved with this strategy. Surgical this talk to a conclusion. Empyema management again talked of in level 2, level 3. If you go to up to date, they say be cautious in this area. They say stay away from bronchopleural fistula and so on. And stapling and all is supposed to be beyond the purview of us medical thoracoscopists. Here you can see an empyema. It's either going to be going through conservative care, chest tubes and all that stuff, or at the right stage in stage 2, we go in. In this case, we have a more aggressive approach. We do go in and try to break loculations, make the pleural space, one and approximate the two pleuras. At the same time, get cultures, establish etiology, and we have seen that it gets them out of the hospital faster. So if you see this video over here, this is always double port most of the time. So 2 ports, this will use a Yankur through 1 port and try and break loculi out there, which is quite effective. And multiple tools can be used here, such as hooks and forceps and so on. Again, I'm not sure whether I'm again a little confusing you, because though people do it, we probably have a few people in the country good at it. You can see how good the pleural space is here now. But at the same time, this is something which is quite challenging to take up. But since the talk is beyond the boundaries of breaking the glass ceiling, we brought it up for completion. This was done under general anesthesia because it's very tough to do otherwise with so much work. Literature, there's a growing slew of literature for medical thoracoscopy guided empyema management for the right early empyema, so as to do adhesiolysis, shorten the course, get a diagnosis, and ultimately improve their outcomes. So to conclude, breaking the glass ceiling was the talk given. The glass ceiling, we banged ahead and went beyond it, and hopefully we have justified what we're talking about. To put things in perspective, pleural disease management has been revolutionized by medical thoracoscopy. It's come into India, inroads, penetration, and absolutely common procedure. It's common procedure penetration has been achieved by MT spreading through the country at great length. The science progressed tremendously. And as we said, the training picked up in the country to make it meaningful and impactful in patient care. What we talked of today is, can we expand the scope? Can we close loops at the next level of care? Can we do the right thing for patients when the need arises for the right indication? This, ladies and gentlemen, was today's talk, and I thank Dr. Nene and the IIB for giving me an opportunity. We said we'll transgress the guidelines, and that's what we have done. Diagnostic arena, therapeutic work, all of them put together for patient good. Today was the example of the panorama revealed and the playing field expanded. How much one can do, how much one wants to do, how much should be done is always a question which can be debated. But by and large, this can be done by the IP doctor depending on his stage of learning, experience, infrastructure, and backup. But I will leave a warning that, all these stunts should not be tried at home is what we used to see when these fancy things were there. So these should not be tried by the newbie, the novice one. But suffice it is to say that even if you're attending and you're getting a peek into this world, you will at least get a good of what can be done in the field by people in the country for our patients for all the right reasons. I repeat this message because I am a Mehta and my most senior colleague Atul Mehta has always come into this country and never let us forget safety, experience, skills, and infrastructure is the cornerstone of boundaries. So he would probably not approve of the way we go ahead and break the glass ceiling. But nevertheless, I stand here in confidence to say that all of this stuff is done with right indication, right thinking, right patient, right intention, right skill, and appropriate economics. Thank you very much.
Thank you, Dr. Ravi. This was a fabulous talk. I think it was very, very exciting because the thing is that we want a thoracoscopy course. We want people to learn the correct things, but at the same time, we want them to know that as you master the art, what all are you capable of and what is beyond the boundary. So, I mean, Ravi, excellent stuff, innovations, thinking out of the box and, taking chances, doing the jugaad. But at the end of it, everything works. So thank you so much for giving us this beautiful view to the beautiful panorama of what all could be done through thoracoscopy, thinking out of the box. Thank you. I'd like to now invite my very, very dear friend, Dr. Nitin Abhyankar, who is the Vice President of Indian Association of Oncology. He's basically going to give us a very, very interesting talk. Everybody's going to be really shocked when they hear about what all he's capable of. Basically, again, Dr. Nitin Abhyankar requires just no introduction at all. He is a consulting pulmonologist and HOD pulmonary medicine at Pune Hospital in Maharashtra. And he's had many, many publications. He is a guy, he has been doing fantastic IP work. We Maharashtrians are so proud of him because I think he does more IP than any of us have ever thought of doing. A wonderful human being, very, very humble, but really he changes his avatar when he is in his room, in his IP room, when he just does everything that is so, so scary and so, so different. So over to you, Nitin. Just waiting to listen to you. Thank you.
Good evening, friends. And this is going to be an out-of-box kind of an experience. I started this particular workshop with a very basic lecture. And this is something which is not at all basic, not really difficult to do, but not really recommended for everybody. So let me take you through this journey of mine through medical thoracoscopic lung biopsy in DPLT. And this is the first patient that I did in year 2004. He had, as you can appreciate, dominant ground glassing and very little microcystic honeycombing. And there was a subpleural sparing also. This was obviously an extensive ground glass abnormality. The extent of the reticular abnormality was less, and he had a severe restriction, and therefore he underwent a biopsy. And as you can appreciate, this is a uniform, homogeneous interstitial fibrosis with lymphocytic infiltrate. And this was a fibrotic NSIP. So there was certain fibrosis and certain amount of mononuclear cell infiltrates and moderate interstitial fibrosis. First case that I did. Why perform lung biopsies in the first place at all? I mean, do you require it in most situations? In fact, not. If I have a classic UIP pattern like a subpleural basal predominance, reticular abnormality, honeycombing with or without traction bronchiectasis, and there is nothing which is inconsistent with UIP pattern, then in a classical UIP pattern, as I've shown on the A, we don't need biopsies at all. These patients are essentially treated without any biopsy. For a radiological pattern which is either non-classical for UIP or for indeterminate for UIP, lung biopsy is largely recommended. You can still have some amount of observation in some of these patients, but lung biopsy is largely recommended in these patients. And what are these patterns which are inconsistent with UIP? Typically, if I see an upper lung, mid lung predominance or a peribronchovascular like this, which is suspected to be a sarcoidosis, then you can do the biopsy, which is transbronchial methodology, and you will get the transbronchial lung biopsy showing non-caseating, typical onion peel kind of appearances. If I have profuse micronodules like this, and I do a TBLB again, I will be getting a good miliary tuberculosis as a documentation. If I have discrete cysts, which are multiple bilateral, but away from the areas of honeycombing like this, then these are bizarre cysts, then often I can make even a clinical diagnosis of Langerhans cell histiocytosis can be histopathologically confirmed. If I have, as I've shown you, an interstitial fibrosis, minimal fibrosis with dominant honeycombing, then the biopsy here was NSIP, which I first discussed. This was a fibrotic NSIP. And if I once can get a mosaic diffuse attenuation with air trapping, with bilateral or 3 or more lobes involvement, I will be definitely getting a transbronchial lung biopsy. Sometimes even a lavage will be enough in this situation. You might occasionally need a transbronchial cryobiopsy, and we'll come to that eventually. But these are loosely formed granulomas of what would be described as hypersensitivity pneumonitis. So where are the indications? One, we want to make a specific diagnosis. This is particularly relevant in younger patients, somebody who has an unexplained fever or a weight loss, somebody with either hemoptysis or suspected vasculitis. Of course, if I have a convincing vasculitis documented by the biomarkers, I may not need a biopsy at all, but I'm not clearly sure on this. Then, if I have an unexplained progression or an atypical or a rapidly changing HRCT finding or an unexplained extrapulmonary manifestation or a pulmonary vascular disease of unclear origin, of course, we would also want to do a biopsy when I want to have a neoplastic or an infectious disease process, which is mimicking an ILD. So in those situations also, I might be needing it. In a nutshell, I want to look for a more treatable process. For example, if I have a suspicion that this is an HP UIP and not a pure UIP IPF, then I would do a biopsy. To predict the likelihood of response to therapy, if I really want to put somebody on, say, mycophenolate or steroids for a long time, I would rather get a diagnosis established as clearly as possible. And once in a while, you might have a patient with a normal HRCT where you have significant hypoxemia and pulmonary distinctions are suggestive of ILD, and you might actually just need a documentation with a biopsy. So we obviously use a huge amount of transbronchial lung biopsies. We have started doing cryobiopsies, and in most centers in this country, cryobiopsy is more available than, say, medical thoracoscopic lung biopsy. We have our experience of around 160 cases so far. And of course, very rarely we require thoracoscopic or a VATS biopsies. Because we are doing this or with emergence of cryobiopsy, this is getting decreasingly needed. Now, a diffuse end-stage lung disease, extensive pleural disease, or severe pulmonary dysfunctions are one of the relative contraindications. You have to be careful in these kind of patients. If I am looking at either a TBLB or a TBLC for that matter, then I will be looking at more centrally located diseases, central lobular disease like sarcoid, once in a while hypersensitivity, lymphangitis, carcinomatosis, eosinophilic pneumonia, alveolar proteinosis, and once in a while it will work very well in a cryptogenic organizing pneumonia also. Cryobiopsies are once again more better situated for these scenarios, same scenarios I'm talking about. And these are examples of this is actually a sarcoidosis. Then this is an organizing pneumonia, which was drug-induced organizing pneumonia. And after documentation that this is a this is a drug-induced organizing pneumonia, patient did very well on steroids and did very well over a period of time, as you can see, over from 2013 to 2014. When you do a TBLB, you're typically doing just around 4 to 6 transbronchial lung biopsies from the areas which are with intermediate involvement. If there is uniform involvement, then lower and both upper and lower lobes are biopsied. And they generally, of course, if I'm doing a TBLB or for that matter TBLC, that is, I would do it from the same side to avoid the risk of bilateral pneumothorax. What are the limitations of a typical TBLB? They are obviously smaller in size, subject to a crush artifact, so on and so forth. And they won't give you what is called as architectural pattern, like NSIP on the right side. On the left side, this is a temporal heterogeneity of a classical UIP. This a surgical biopsy can give you, VATS biopsy can give you, and medical thoracoscopic lung biopsy can give you. Cryobiopsy occasionally can give you the pattern so beautifully. So let's now come on to the idea of medical thoracoscopic lung biopsy, which is our forte at this point in time. It was being practiced in Europe since 1990. And 1998's Vincent Kesti's paper here shows that what is the kind of, this was a study about what kind of biopsy size was relevant and was it useful in managing. And they had shown that it was useful in around 85-90% of the patients. We started performing medical thoracoscopic lung biopsy since around 2004. And we always have used a rigid fluoroscope with either 1 or 2 ports with a conscious sedation. We have never used a double lumen tube at all. We have never ventilated the patients with a intubated ventilation. So that was never needed. Indication for lung biopsy usually has been idiopathic interstitial pneumonia with non-classical or a possible UIP pattern, which was recommended at that time. Today it is indeterminate pattern for UIP. Last so many years, we have done nearly 160 instances of thoracoscopic lung biopsy, and the diagnostic yield has been as good as 99%. There's only one failure in the entire year. The commonest histopathological pattern was UIP seen in around 70 cases when we had never really taken up classical UIP for a biopsy. NSIP, fibrotic NSIP, chronic HP UIP overlap, cryptogenic organizing pneumonia plus minus NSIP, and then sarcoid and various other patterns and some rarer diseases also, which I will refer to. Now, this is how the biopsy is done. We use a long forceps, which is cupped forceps, and you hold the tissue and apply a quadric current on a coagulation mode of around 40 watts, a small amount of dosing which is required, and then you start pulling it. And when the tissue becomes loose enough, you pull it out. The outer surface of the biopsy is coated, which will get coagulated, but the inner part remains very intact. And usually, these biopsies will not bleed ever at all. In fact, if you look at this very carefully, what I'm seeing is absolutely no bleeding. The main risk remains of air leak because this is a partially collapsed lung. Right now, you are not seeing any air leak at all. But eventually, when you inflate this lung, when the lung gets inflated on its own, and this is a moving lung, so you have to have some hand skills here, which is necessary. You can take all 3 lobes and we'll land up taking up to around 6 biopsies from all the 3 lobes. Middle lobe sometimes gets avoided, so 3 from the lower and 3 from the upper, depending on what you are doing. And you can take as many samples as you need to without any problem whatsoever at all. So that kind of a process is possible, and that's the end result. So let's take a few case examples and quickly try and understand how useful is this procedure. This is Mrs. AG, 52-year-old female. She's symptomatic for progressively worsening external dyspnea for about 8 months, has typical bibasal leathery rals on examination, spirometry shows restriction and reversible or obstruction. And the radiology typically reveals that there are interstitial shadows, there is reticulation, but there is no honeycombing. And you're not really sure. So would you call this possible UIP or not is a little bit of a debate here. I am not too sure what you will call this. And this is the other reconstruction of it. It definitely shows absence of honeycombing in complete way, but the reticular shadows are dominant. And I may be calling this possible UIP. This is the histopathology. This does document all the classical of normal versus abnormal, metaplasia, fibroblastic foci. So all the enchilada of what is called as classical UIP IPF. So severe metaplasia across fibrosis, and there are areas which this is a fibrogenic focus. So all the classical features of a UIP-IPF were documented. This lady survived on antifibrotics alone for around 9 years or so and died about 2 years back. Again, this is a enlarged view of fibroblastic focus. So from a possible UIP or a indeterminate pattern, we moved on to a definitive diagnosis of UIP, and therefore only antifibrotics were given to this patient. 52-year-old patient, you would be really cautious because you would expect something else in addition like an HP UIP, but that was not to be. Here is another case, which is 45-year-old male presenting with exertional dyspnea and cough for 6 months, no fever, no weight loss. And this was kind of a pattern which we were wondering whether this is organizing pneumonia kind of a pattern, and these are better images of the same, and we were not sure what is this. We did a biopsy, and our histopathologist reported this to be a biopsy which is showing cryptogenic organizing pneumonia. So for initial part of first 6 months or so, we were treating with steroids again. So the treatment was right, but we had not picked up something which Dr. Churg, when we were doing the ILD icons conference, Dr. Andrew Churg was involved, and he picked up in this, when this slide was sent to him, he picked up those so many eosinophils which was theirs, and this was actually a chronic eosinophilic pneumonia which was mimicking. Actually, it was a chronic eosinophilic pneumonia which was mimicking a cryptogenic organizing pneumonia. Of course, the treatment remained the same, but the prognosis changed, and this patient has done very well and is till date following up for good 12 years. So the last case I'm presenting is 22-year-old female patient, cough, dyspnea, fever off and on, related dyspnea worsening 4 years, and radiology showing this is in February 2016. This is the kind of a pattern where you are thinking some kind of a bronchiolitis here, and we are not sure exactly what type of bronchiolitis is this. So we wanted, obviously people wanted a BAL and a TBLB, and this was in a different center where the BAL and transbronchial lung biopsy was done, which was with the II guidance. And well, I mean, it was consistent with bronchiolitis obliterans and the other possibilities that they had mentioned. The final diagnosis was asthma-related bronchiolitis or RBILD. Of course, this patient was not a smoker, so that RBILD was not that relevant. So would you now treat this as this is, or you would want a larger biopsy specimen? That was a question. And with this kind of a debate and some trial of even steroids not working very well, we decided to opt for a medical thoracoscopic lung biopsy. So we did that despite a steroid trial failing. And then we finally did this, documented the worsening even on steroids, and we did a medical thoracoscopic lung biopsy in this particular patient. And then this is what is the typical picture, what was seen. And this description I will read because I don't understand the technology so much, so but you can appreciate the kind of vacuolation which is so very classical. And this shows what is called as preserved architecture, peribronchial fibrosis. There are inflammation, lymphocytes, and polymorphs and eosinophilia also netted a local collection of foamy histiocytes. And this is important. This kind of foamy histiocytes in this kind of a pattern, which was evident, was classical for what is called as diffuse panbronchiolitis. There are very few reported cases in Indian setting. It's more seen in the Japanese and the East Asians, other countries, but we do see very small numbers of them. This patient did brilliantly well on a very tiny dose of steroids, but clarithromycin given in a correct, good dose, and has continued doing extremely well on clarithromycin, which is the drug of choice for diffuse panbronchiolitis. And with that, I hope I have shown you enough to excite you a little about this extended indication of what is called as we would limit ourselves majority of the times to this, but in small situations, small number of patients, when the need is there, and when the patient is not really in a zone of getting a in a zone of not getting a surgical biopsy. Of course, we'll get into the discussion eventually. Wherever I use it today, our use of medical thoracoscopic lung biopsy is actually going down. In the last 4 years, we have hardly done just 2 or 3 cases. So I think this is definitely going down in numbers. TBLC is coming up in a big way. TBLB is adequate in majority of patients, and the CT scans have changed so much that we don't anymore require this kind of biopsy anymore at all. But at the same time, this technique is available, and that technique is relatively way cheaper and way as safe, I would say, as VATS biopsies is. So I think worth keeping in mind as an extended indication, and keep it out of the box, not in the box right now. With that, thank you very much for your patience.
Thank you, Dr. Nitin. This was fabulous. I think this is really daring. And I think everybody who's heard this talk are going to be very motivated to do something which is just so out of the box. So thank you so very much. And I'm thrilled to let you all know that we have currently 1,967 people, 1967 people who've logged in, which is the highest so far. So fantastic show, brilliant faculty. So can we have all the videos on so we can start with the panel discussion? Great. So before starting the panel discussion, I'd like to introduce all our brilliant panelists who are doing fabulous work and who we are so very proud of. So I'd like to first introduce Dr. Ajay Ravi. So he's basically working at Trivandrum, Kerala at the KIMS Hospital. He's a consultant interventional pulmonologist, honorary consultant. He's basically done his IP fellowship. So we are so very proud of him. IP is his passion. He's doing such good work. And entire Kerala is really talking about him. He's done his European Diploma in Respiratory Medicine in 2022. He got the ICS Travel Grant for the ERS International Congress 2019, Diversity Travel Grant Award of ACCP 2018, and National Best Orator Award, Torrin Young Scholar Award 2015. This is brilliant. Congratulations, Dr. Ajay, and we are so happy to have you on board.
Thank you so much, ma'am, for the lovely
Yeah.
words. Thank you, ma'am.
Yes. Looking forward to listening to words of wisdom from you. After
Sure.
Dr. Ajay, I'd like to introduce a very dear friend of mine, Dr. Parmez. So Dr. Parmez he doesn't require any kind of introduction. He basically is a very accomplished pulmonologist. He works at Kochi. He's a governing body member of Indian Chest Society. He's a secretary of Kerala chapter of Indian Chest Society. He's a vice president of Cochin Thoracic Society. He was a treasurer of NAPCON 2019. He is the treasurer of BronchoCon 2024, which is the event to look out for. Everybody is just so looking forward to going to Kochi. He's the associate editor of Journal of Advanced Lung Health and awards recipient of Best Young Pulmonologist Award, and just so many things. So a warm welcome, Dr. Parmez.
Thank you, ma'am. Thank you.
And now I'd like to introduce Dr. Kaushik Muthuraja. He's a very dynamic chest physician from Chennai, and he loves to do thoracoscopy, and he's doing fantastic work in interventional pulmonology. I'm just so very happy that I know him, and very interested in academics, many publications, and he loves to teach. So Dr. Kaushik, a warm welcome to you. Dr. Ravi, can we have your video on, please? Okay, okay, thank you. So I'd like to start the question with my dear friend, Dr. Parmez. So the first question to you, what are the indications of double port thoracoscopy?
Yeah, thank you, madam, and IAB for letting me one of the panelists, first of all. And thank you, Ravi Mehta sir and Nitin Abenga sir, for making life of ours very easy, because it was too lucid and like you just watch a movie with both these speaking, like and you know. And regarding your question, it's already been answered by Mehta sir about the double port. Yeah, I got a disclaimer. We do a lot of single port flexi rigid scopies, and we also do some kind of therapeutic work with that. And we rarely do a double port technique. But yeah, in certain instances where we have to go for double port technique, even with a local anesthesia, not during the general anesthesia. It's a local anesthesia is when you have an empyema or when you have a loculated or a complicated pleural effusion where you may need to do an additional lysis, then you may need to go for a double port method. And also, while using the rigid thoracoscope, you may need to get a good visualization of areas. A double port method is better utilized, and also you can do certain electrocoagulation and other advanced method when you go for a double port method. And also, as Ravi sir showed in his talk, in a persistent air leak case, you can always visualize and do the therapeutic procedures using the double port method. And quite interestingly, with the double port, he used the younger section to remove all the additions. These are the major indications by which we use the double port method. But most of the diagnostic purposes we can go about and do with a single port method.
Wonderful. So basically, the thing is that if you want to just do a biopsy, maybe single port is fine.
Right.
If you want to do something fancy, then double port is very, very useful. So now
Yeah.
coming to Dr. Ajay Ravi, because I'm sure you've been doing this. So how will you plan? So, some of the questions are a little repeated, but that's because we are addressing people who are listening to this for the first time. And therefore, we just want to make sure that they registered correctly. And I'm very, very happy to say that we already have 32 questions. And I'm kind of just asking the question that have been asked. So, Dr. Ajay, can you please tell us that how would you plan doing a two-port medical thoracoscopy? And do you require a double lumen tube? How do you do it?
Thank you, ma'am, for that question. And first of all, let me thank IAB as well as dear speakers for this wonderful session, and for Amita ma'am to organize such a wonderful session. And this is the 8th module, and we are having such a large participation. So let me answer the first part of the question. That means how we plan. So in each and interventional pulmonologist, before you go for a thoracoscopy, you should have the plan that whether you are going for a single port or a double port. How can we decide that? We decided from whether what are your plan, whether you're going just for as Dr. Paralesh and Ravi said, whether you're going for just a diagnostic procedure. So you usually go for a single port, but for like out of the box, all these additional complex and you go for multiple ports. So the first step is, before you start a procedure, you have in mind whether you need a single port or a double port. So once you have planned that, the next thing is you do the second week give the second port. We usually do that like at least 2 space in line with the first port, at least 2 space distance from the first port, so that this helps in the better visualization. And this port may be a smaller port rather than the first. So mind you, you usually do this with a rigid thoracoscope, and this helps sometimes just for diagnostic purposes. It may help for visualization of remote lesions like surfaces and all. But for complex procedures, when you want to reach that right, so for complex like additional lysis and all, you may need a double port. And one more thing is that the second port is usually inserted under vision of the through the first port. First port, you visualize the site of entry and you mark it, and then you insert your second port. So these are the part about the second port. Now coming to the second part of the question, whether we need a double lumen tube or not. So when we need a rigid thoracoscopy or whether this is flexi rigid thoracoscopy, usually with the conscious sedation, when the patient is conscious and breathing out of herself, usually we don't need a double lumen tube. When the conscious sedation, once the pleura is reached, we get a pneumothorax and the lung collapse, and we get enough working space in there. But that is usually for the diagnostic purposes. But in case you are going for a longer procedure like an additional lysis or a drainage of empyema or a painful procedure, usually we require a general anesthesia, because it takes sometimes hours to complete the procedure. So in that cases, we need a general anesthesia usually. But when a general anesthesia is given or a positive pressure ventilation should be given, that you may not get an enough place when both lungs are usually ventilated. So in procedures, longer procedures, complex procedures, when you expect that the time duration is going to be more, you better go with the general anesthesia, and that's also with the double lumen tube, so that the working lung is collapsed when you require it. Either you can use a double lumen tube or you can use an ET tube with a blocker, whichever your anesthetist is comfortable with. But for longer procedures, especially, we have to go with the DLP.
Okay, wonderful. That's great. You need not always have a WBIN endotracheal tube, but if you're doing something really long, you're doing something complicated, you may need to have it. Okay, I'd like to come to Dr. Kaushik. So, Dr. Kaushik, can you please tell us about the anesthesia considerations when you are doing a double port thoracoscopy, and what is the role of intercostal nerve block?
At the outset, I thank Dr. Nene and IAB for giving me this opportunity to be in this wonderful panel with great colleagues here. So, as far as the anesthesia component is concerned, if you are planning for a double port, we can either go with conscious sedation, or depending upon the space available, you can choose, like Dr. Ajay said, you can either choose a general anesthesia with the we usually do under blockers. We have never used double lumen tubes so far. We use a single ET tube, and then we use a bronchial blockers, and then get enough space. And for double port, I think that works well. But recently, we did one case in a paravertebral block, which also had a very good effect. But intercostal blocks, I think you have to give multiple level intercostal blocks when you're planning for a double port thoracoscopy. So if you have a very good anesthetist who can help you with that kind of a block, then probably you can go ahead with that as well. So that would be my take on double port anesthesia for double port thoracoscopy.
What would be the advantage of the intercostal nerve block, Dr. Kaushik?
I think it's only the opioid reduction which we are talking about, and then probably the post-operative period will be less eventful. So that is the only most advantageous component of intercostal nerve block is that.
Correct. So maybe daycare thoracoscopy, it would be probably very, very useful.
Yeah,
When
it will be
daycare,
very,
we
very
might be
useful, but
able to-
then I think your anesthetist have to be well trained in giving multiple level intercostal blocks, especially when you're trying for a double port. The selection of area might differ, so I think that kind of expertise is required.
Okay. Very good. Thank you. Coming to Dr. Nitin, should beginners, this question is asked at least by 4 people in the chat box. So the question is, should beginners handle loculating empyema? When to involve a surgeon?
Very frankly, I think I would not recommend people to start handling a loculated empyema. I think it should be a large or a reasonable, moderate to large undiagnosed pleural effusion where you will start. You should not start with the hydropneumothorax. You should not really start with a loculated empyema. That's not a good time for beginners to start. So I think that's the first message. When you have grown into it for a good 2 years, 5 years, 100, 200 cases, and you have done them successfully, then in any case, one way or the other, you are going to come across some adhesions or the other way. And then if you extend it into that territory, it is justifiable. But then be a little careful. While I'm on it, I might as well add to what he was saying about the multiple intercostal blocks, that so-called multiple intercostal nerve blocks are not necessary if you inject it into what is called as in fact that is what is realistic, that you don't have to inject into multiple intercostal spaces. You do it into infraspinatus muscle, and that has all the nerve endings in that area. So a large part of the 2 or 3 or 4 spaces which you want to anesthetize, the infraspinatus, you inject ropivacaine, and ropivacaine acts for about good 10 to 12 hours. So if you are planning a daycare procedure, I think that, I have seen this being done by Arjuna and Pattabi in Coimbatore, and they do a daycare procedure. That means they are discharging the patient by evening. And if you are doing that, the ropivacaine comes as a very, very important drug which can, take care of your anesthesia needs and postoperative pain need also. So to a large extent, your anesthesia drugs get minimized, and the postoperative pain drugs also get minimized.
I think what you're talking about is a paravertebral block.
Yeah, it's something like that. So you
Yeah,
get
so
it
it's a
between.
paravertebral block. I think there is a difference
So
between
multiple intercostal blocks is very tedious to do,
yeah,
and
yeah. But
Yeah,
anesthesia
when you
will not be
do,
very keen to do it for
yeah,
a
when
small
you
procedure like this.
Yes,
yes,
yes.
yes. But
So
when
actually,
you talk,
I agree. What Dr. Kaushik answered was what I asked him, and I'm very, very happy, Dr. Nitin, that you added more light to it. So I'm very, very happy that the discussion is becoming more and more enlightening. So great. So Dr. Nitin has told us that please be very, very good at your thoracoscopies before you want to go into empymas. I'd like to come to Dr. Ravi now. So Dr. Ravi, you actually told us, but I want to ask again because it was pretty fascinating. So, when and how would you attempt a visceral pleural biopsy? What are the complications? And how would you handle these?
Right. So as we talked about, Amita, thanks for the question again. As you said, people may be logging in late also. The whistleblower biopsy part of it we mentioned is like a procedure of exclusion. Normally, the lesions which are there, which cause a pleural effusion, are usually called kissing lesions. So they are reflected in the parietal pleura and the visceral pleura. So the first attempt of a pleuroscopist should be to extensively look everywhere, the common areas being the gutters, the anterior gutter, the posterior gutter, and the diaphragm are the areas where you can find these lesions. If you can't find it there, then you notice a lesion on the visceral pleura. Then a conscious decision is taken about the need for biopsy, the risk of two things, as we talked about: air leak and bleeding. Bleeding is usually not much at all. It's air leak, and that's when you take a decision. Okay, that I can do this. When you do this, you require steady hands, a good operator, because you're doing it under conscious sedation. So by and large, your lung is moving over there, so you have to make sure that you are steady in your hands, your operator is moving the forceps appropriately, and you try to pluck it as away from the pleura as you can. So often the lesion will allow you to just take it off there, and it's something which you can even avoid the vessel pleural surface. Even if you wind up plucking it, Nitin has shown he does a full biopsy with the rigid scope, but we're talking semi-rigid here, then you can take it and try, and if the lesion is loose, it'll come off. Sometimes lesions are closely stuck and then the whole lung starts plucking up. So that becomes a problem. So little learning curve and experience is required. Finally, at the end of it, you can check for air leak by pushing some saline into that area. But if it's a worry of leak or there is a small leak, you can, we usually try to take a small piece of parietal pleura and put it there. And as lung expands, the parietal pleura or some other area out there will stay on there and give you that little patch as long as it stays over there. Somebody in the chat box I think they put some other stuff also over there, if I'm not mistaken, to try and do aerostasis. And that's pretty much it. Don't take too many. Take, as much as required. In the pleura, usually one also may be sufficient, but two or three is advisable. And usually that's enough for all sorts of material, right from histopath to processing for malignancy or for tuberculosis or infection. So this more or less is the technique. So sparingly done, cautiously done, pro con analysis in your mind, a good technique. Watch the leak part of it and try and put measures to do it appropriately. One small tip is that if you don't expect the lung to expand, for example, if it's a trapped lung, then be careful. Because if you have a leak and the lung is not expanding, you're looking at a persistent air leak, which you thoroughly want to avoid.
Okay, thank you. Thank you very much. Okay, I'd like to now come to Dr. Parmez. So, talking about lung biopsies, so this is very, very interesting. Should we really do a lung biopsy in a patient with idiopathic interstitial pneumonia? And in which patients do you want to do a lung biopsy in today's day and age?
Yeah, means with the present guidelines that are available nowadays, and also depicted in the previous speakers also. If the patient a good clinical and radiological picture, and you are pretty much sure that this particular clinico-radiological picture, which I mean is the HRCT picture, is suggestive of a UAP. okay, a classical UIP, you won't go for a biopsy because even the guideline says that you need not go for a UIP. But there are certain instances where you have to go for a biopsy if the diagnosis is indeterminate, or if you have got an alternate diagnosis, or if there is any other suspicious lesions in the lung. Maybe you are thinking about dual pathologies or something like that. Along with that, because there is always a risk of malignancy associated with these interstitial lung diseases. And also, if you're suspecting lymphangitis carcinomatosis kind of picture, and even in hypersensitive pneumonitis also, there are certain indications while by which you have to go for biopsies. If your clinical history is not correlating with the radiological CT parameter, then you may need to go for a biopsy, even in a non-fibrotic hypersensitive pneumonitis as well. And obviously, for other diseases like sarcoidosis and all, you may need to go for a biopsy to get the diagnosis and to differentiate it from other causes of granulomatous diseases like tuberculosis as well. So these are the certain indications by which you have to go for biopsies in interstitial lung diseases, and also for cryptogenic organizing pneumonias. Patients may be presenting with high-grade fevers and not responding to antibiotics. Patient may be on antibiotics from other part of the any other hospitals and not responding, and typical CT picture may not be there. Then you may need to go for a biopsy for suspected cases of cryptogenic organizing pneumonia as well.
Okay, great. I mean, that was great. Fine. I'd like to come to Dr. Ajay. So basically, the thing is that we can do biopsies, we can do transbronchial cryobiopsy, and the great Dr. Nitin Abhyankar, I think the only in the country, probably only in the world, also does medical thoracoscopic lung biopsies. So basically, what would you prefer between the two? I mean, rather, when would you prefer one over the other? When would you prefer medical thoracoscopic lung biopsy over TBLC, and what are the complications?
So I will answer that question. So I'm answering that question right in front of the pioneer, one of the only one man and who has so much of experience in fluoroscopic lung biopsies. So we can't compare both the procedures because actually they belong to two different eras. Means Dr. Nitin started in 2004 and all, and we have cryos only maybe for last a decade or so. So when I as Dr. Nitin has elaborated in a thoracoscopic medical thoracoscopic lung biopsies, we are talking about a rigid thoracoscopy. We have rigid instruments, probably two ports, and rarely a single port, probably two ports. And but the advantage is that we get a bigger chunk of tissue and bigger chunk of biopsy, so that we get that structural, architectural, everything for diagnosis of an IL. But it has its own complications, probably their leak, which in experienced hands like Dr. Nitin's can be managed, but not for anybody that don't think that that is so easy and all, and to be managed without a surgical backup, it's not that easy. Now coming to transbronchial lung cryobiopsies, now most of us have easy access to that, and it works like our flexible instrument, our routine bronchoscope. We have flexible probes, and with fluoroscopy and all these occlusion balloons and all, we do this procedure quite safely, transbronchial lung cryobiopsies. And if you see the literature, you can see that we get comparable results with surgical lung biopsies for our transbronchial cryobiopsies also. I couldn't find much of head-to-head comparisons between the medical thoracoscopic lung biopsies versus cryobiopsies, but we get comparable results like some surgical lung biopsies. So I think it's just it's a matter of your availability, your skills, and your experience. Because most of us are now being trained with the flexible instruments, with the flexible cryoprobes and all, that comes more handy. The procedure is more quick, complications are less, maybe hospitalization is less. And we are comparing a procedure which requires 100% chest tube versus a procedure which requires maybe less than 5 or 10% of chest tube, that is cryobiopsies. So that chest tube part increases your hospitalization, and also the complication may be a little bit higher with the medical thoracoscopic lung cryobiopsy. So
Right. Point well taken. Medical thoracoscopic lung biopsy is more of early. TBLC, if at all, is more of bleeding. But of course, the Fugati could be the lifesaver. Dr. Nitin, if you can just add on, when would you prefer the medical thoracoscopic lung biopsy in particular over TBLC?
Yeah,
Since
I
we
think
are doing everything.
yeah, I have a very clear mind on this that anything which is peribronchocentric kind of a thing, HP, sarcoid, I'm more comfortable doing a TBLC, and it is easier to perform. It can be performed in little sicker patients also. When I have a little stabler patient and I am expecting something like an SIP, I really want to sort this thing out between say NSIP and SIP fibrotic, or if I have a only indeterminate pattern and I'm really maybe missing out on something important. For example, I think it is UIP, but the eventual histopathology shows me granulomas and ill-defined granulomas, and it might be HP. So and this has not been sorted out by a transbronchial lung biopsy. Then I would opt for a peripherally approached procedure. And a MTLB is in between, say, a TBLB and a VATS biopsy. So it sits somewhere in between. Of course, if you really see over a period of time, with the advent of TBLC, the indications of MTLB have been going down. So we have been doing less and less. In the last 4 years, we have done maybe 3 or 4 of medical thoracoscopic lung biopsies and 5 or 6 of TBLC. So I think the numbers are gradually increasing in favor. And as such, if you really look at it, there was a time when we were doing 12 medical thoracoscopic lung biopsies in a year. Today we are doing one in a year, something like that. So I think the numbers of per se of the indications of biopsy per se are decreasing because of a better and better HRCT. So I think and better guidelines related to HRCT and people like Amita who are teaching HRCT to the whole country.
Thank you so much. I'm really very happy and floored. Okay, coming to Dr. Ajay, excellent answer. Thank you, Dr. Nitin, for adding on, because when it comes to MTLBs, I think you are the only master over here who can talk with authority. So now coming to Dr. Kaushik, I'd like to ask you, when will you recommend against either doing an MTLB or against doing a VATS? And what are the alternative options and what would you prefer?
I think I would per se perhaps take this question as some kind of a contraindications for doing VATS and
Yes, yes.
MTLP. So I think per se, except for pleural symphysis and very dense additions, there are no absolute contraindications. But there are certain conditions which would actually increase the mortality and morbidity in certain patients, like patients with pulmonary artery hypertension and patients with FVC of less than 50 and DLCO of less than 30, and patients on high dose corticosteroid therapy and poor functional status. All these patients, I think we have to be very cautious and alternate. Probably, I think the one of the safest option would be TBLC in these patients. So I would recommend that. And if that is not possible, I think a strong multidisciplinary team along with your radiologist, I think that should give us a clue on how to direct this forward. And probably you can involve your rheumatologist as well. So that would be my.
Only TBLC, no TBLB?
I think the yield of TBLB would be little less compared to TBLC. So I think in patients who are not fit for some kind of procedures which will yield as more report, I think more diagnosis. I think we should stick on to one procedure which will give us higher diagnostic yield. So I think we'll go with TBLC in this case. So.
Okay, great. So I basically agree with you, but I just feel that sometimes patient may be unwell to undergo VATS, but they might be quite well to undergo TBLC or TBLB. So if TBLC is not available, you're suspecting sarcoid or HP, organizing pneumonia, lymphangitis, then you might as well do a TBLB instead of, empirically treating. But point
Yeah.
well taken, TBLC is definitely
one one add-on is like few centers have proven good yield with TBLB when they are doing with bigger size forceps. So like
better.
the ones which they use for gastro. So few
Great.
centers have proven good diagnostic yield with such kind of forceps.
Wonderful, Dr. Kaushik. Thank you so much. Coming to you, Dr. Nitin, instrumentation and common complications encountered with MTLB. There are many questions. Let's really talk fast so that we can cover everything.
I think the instrumentations are fairly simple. generally it is a one port or two port. What we started doing was, in fact, we started doing it two ports initially, and we were doing two port for a good number of time because we wanted a larger forceps. A large cups forceps is what is required, and it has to be nearly 1 centimeter in diameter. Then you will get a yield which is like, if I add 4 or 5 specimens or 6 specimens, then it will be 2 by 2 centimeters. So it will be a good size chart. It is equivalent to 1 Watts biopsy. Very frankly, a staple biopsy is much larger in size, but it comes only from one area. So here you are getting it from multiple areas, and therefore the issue of concordance, discordance gets sorted out. If you really ask me, all that you need additionally is cautery. I haven't used APC in the pleural space much, but electrocautery is good enough. I haven't used anything else, but Ravi has done everything there in that territory. So he has armamentary of instrumentation. But for a medical thoracoscopic lung biopsy, you don't need anything more than this, very frankly. And a little bit of a bleeding is not a big problem because it works as a blood patch. So I don't suck it out. In fact, I would rather leave it there and allow the lung to expand in the presence of the blood, and that whole thing glues up. So we might temporarily keep it, after it starts nearly completely expanded, just clamp it for a little while and then declamp it, and then allow that blood patch to work, and it heals more beautifully.
Wonderful. That's great. Wow,
If I
super.
can, if I can add one more point, I think in where there is a moderate to large bleed, where you can't locate where the bleed is from, there is a beautiful tool called a suction cautery, where you suction the blood and apply cautery at the same time. So it is one of a very good tool which I think beginners should have. So it will be very useful for them. Just one point which I wanted to add.
Great, great.
Particularly
Wonderful.
when you're lost, yes, absolutely. Great.
Yes, superb. Dr. Ravi, now asking you, because we are talking about biopsies. Are you there, Dr. Ravi Mehta?
Yeah, I'm here.
Yes, okay. So now that we are talking about biopsies, I want to especially ask this question to you because I know that you are one of the person in the country who's done maximum number of TBLCs. So the thing is that I want to ask you, in today's day and age, do you think TBLCs are on a decline, and why? And if at all you're doing, what are you doing them for these days?
I think it's extremely controversial, the question Amita is asking, because I know her answer, I know Nitin's answer now. So I'm left with what am I going to say at this point? So going by the textbook indication, non-UIP and CTD-ILD, sorry, if it's UIP, CTD-ILD clearly, or HP with clear exposure, no biopsy. As per guidelines, which as far as last check, nothing has changed, everything else you can biopsy. So that is the playing field. After that starts individual expertise. I'm this good, I'm that good, HSCT is excellent, I'm confident of my clinical diagnosis. And then you can, then a call comes after that. So the algorithm is very clear, guideline and what we do after that. So this is where we stand. Now, we have still been following the guideline. So if it is any of these, not any of these three, which are clear, categorical, and excluded from the biopsy thought process, we will offer a biopsy. And then you'll be quite surprised at the findings which come out. I'll just take half a minute more. The other value addition we have found in biopsy is that often there is inflammatory signal which we can define much better on biopsy. Histopathology and the lavage cell count, it has its huge value. So the inflammatory versus fibrosis comes out there. Surprise diagnosis is often happens out there. And lastly, is categorical. Once and for all, you know what you're dealing with, so the treatment accordingly can be tailored, and the pathway to lung transplant, if at all, is more streamlined. So I think we can talk of an expanded indication for biopsy above and beyond only the plain histopathology, which is something some centers will exercise.
Okay, great. Thank you. But do you agree TBLCs are coming down or no?
I think we're still doing significant, but
Okay,
don't put crosshairs on my temple for this.
okay, great. We got the point. Coming to Dr. Parmez, again, I'm telling everybody, let's be really very, very short because there's just so much to cover and we are getting more and more questions from the audience. So coming to you, Dr. Parmez, now changing gears. So what is the role of thoracoscopy? True role of medical thoracoscopy in a patient of primary spontaneous pneumothorax or secondary spontaneous pneumothorax. What is the role?
Yeah, as far as the pneumothorax is concerned, the Role of thoracoscopy is, one is diagnostic. You can always see if there is a bulle or something like that, and you may not be able to do a therapeutic procedure with a flexi-rigid scope. But yeah, you can at least have a diagnosis. 1 month back, one of the patient was referred to us with the suspected loculated pneumothorax versus bulle in CT. And in those cases, we can always go for medical thoracoscopy to see what it is, and whether it is a loculated pneumothorax or a bulle. And then we did a VATS bullectomy in that particular patient, and he's doing particularly well in this one case. And also, as mentioned, you can always go for therapeutic procedures, like if there is a persistent air leak or something like that, then you can, like Abhengar sir does, he can go for certain set of individuals only go for that. But you also need to know about when to go for the indications, the BTS guidelines. If the pneumothorax is a second pneumothorax on the same side, or a contralateral pneumothorax, bilateral pneumothorax, and if there is a persistent air leak, then these are the indications by which you go in and see the pleural space with a thoracoscope. Thank you.
Okay, great. So that was fabulous. Okay, great. So now I'd like to
Also a non-expanded or a difficult to expand lung, then also you may need to go in and see what is happening inside the pleura.
right. So basically, it's very, very important to know what is the cause of pneumothorax, whether there are bullae, because very often Blebs bullae could be missed on an HRCT chest, which you may find. And then you want to decide, is it going to be pleurodesis done by you, or you need to call in a surgeon. So great. So a patient with spontaneous pneumothorax.
The therapeutic indication definitely for pleurodesis. The powderage as well as the slurry that you
Can you just do it? Absolutely.
Yeah,
so I think it's
definitely.
fantastic. It's really a part and parcel of management. Okay, I'd like to come to Dr. Ajay Ravi now. So again, changing gears. So what about using additional equipments, while you're doing thoracoscopy? And would you prefer doing a cryobiopsy for every biopsy, or you have specific indications and why?
It's actually quite a straight question. Usually, for thoracoscopy, not much of instruments are required, as Dr. Nitin already told us. Usually, we need your thoracoscope and your biopsy forceps, all of that. And sometimes, in case of bleeding, you may require electrocautery. That can be your flexible electrocautery for your electrocautery for hot forceps, which also can be used for hemostasis when you use it like a blunt probe. And then is the cryo. So cryo, it's usually not used as a standard instrument for such an indication. It is usually that when we go in and you find that the lesion is like so hard, like sometimes a metastatic malignancy having a very scarce pleura, rock hard. When you go with your forceps, sometimes you may not be able to get a biopsy even after trying so much of times. So that is when the cryo comes in, because it gets a big chunk of tissue in less time. And there have been cases in situations for us where even a cryo was not working because it was so hard that the pleura was not coming at all. Then we had to go with the electrocautery knife to make a square cut of the pleura, then put the cryoprobe in the middle and take that square piece out. Such a hard pleura we had. So these are very rare situations. Otherwise, usually a cryoprobe gives you a good tissue in there. And one more useful situation which I found is that when there is a long-standing pleural effusion, most of the surface of the pleura may be covered with some inflammatory or this thing sample. So if you get a forceps biopsy, you may get only a superficial this thing. But if you want to get a deeper biopsy in such cases in a thicker pleura or thicker parietal pleura and all, you can get a cryobiopsy. Rest of it, I think there is no hard and fast that cryo is. We go in and make sure that cryo is to be used, but it usually goes in when we find it, when it is needed, we use it. That's it.
Wonderful. So point very well taken. If it's difficult to grasp the pleura, if you can't really get any pieces out, then you must do a cryobiopsy, because otherwise you'll end up sampling either nothing or only the superficial stuff. And I also like the indication he said of the pleura is really studied. And I really liked, you all made a window with a cautery, and then I think so this is again innovations, very, very nice. Great. Now coming to Dr. Kaushik, again changing gears. So is it advisable to use APC with flexible fluoroscope? And what are the complications? Dr. Ravi Mehta does it, but I just want to know your view. You are muted, Dr. Kaushik.
Sorry. So my personal view on that is, if it is being tried for bleeding per se, I think cautery is a very good tool. So I don't think there are a couple of things which you have to know about pleural bleeds. One is a venous bleed and one is the arterial bleed. For venous bleed, I don't think you have to do anything. You just let it be and then it gets settled by on its own. If it is arterial bleed, it's going to settle with your cautery. But if there is a provision for APC, if you really need to use it, if it is not settling with your cautery, then probably you can use it. It can be used through your flexi rigid scope as well. So that is one thing. But I came across a very beautiful article, Chinese article, where APC is being used for reduction of bulla through a medical thoracoscope or through a rigid thoracoscope. So it is a very wonderful article which I recently came across. So where they used APC through single port thoracoscopy to do a bulla reduction.
That's very interesting. I've never really come across this. What are the complications?
The only thing is you have to puncture the bulle and then see if there is any nearby large vessels. If there is no large vessels, you fire
I
the
meant,
APC.
okay. No, got it. I meant complications of using APC with the flexible scope.
So,
I don't think there's any
Okay, fine.
can I just add one point?
Yeah.
What we find when we use a cautery or an APC inside the pleura, when compared to that we use inside the endobronchial tree, is that, as we all know, the parietal pleura is a sensitive structure. So when we use an electrocautery or an APC, there is a chance, especially when we are doing it in the conscious sedation, the patient can have pain and have the feeling of that pulse. So it is necessary that we use educate local anesthesia or put some lidocaine or something that so that the patient that pain concern is also addressed.
Okay, great. Wonderful. So now I'd like to come to Dr. Ravi. What are the complications of using cryobiopsy in pleura?
I think what was talked about, and just to reiterate, it's by and large a bleeding risk. If you wind up sampling on the vascular area or that notorious and nefarious intercostal vessel sitting below, because cryo comes with a yank. When you yank, it's uncomfortable, and you can yank stuff below also, which has not been frozen. And the second is sometimes it's very difficult because it's a serous pleura, you just can't get a grip on it. And it's a very uncomfortable feeling to pull. Truthfully, I don't think there's many indications left. With a good rigid scope or other instruments, very few cases will require an additional cryobiopsy in the pleura.
I think a rigid biopsy would do most of your work.
Yes, I completely agree with you. Yes, correct. Thank you. Coming to Dr. Nitin, what he's the best at, the only person doing it. So Dr. Nitin, staple-aided biopsies be done in MTLB? If we do it, won't it be safer? And for how long do you normally keep ICD in?
Yeah.
I think
First, what we do in medical thoracoscopic biopsy, we are Indian in thinking, and you don't want a recurrence to happen. And if that recurrence is going to be happening and the patient is getting readmitted or something of that sort, so just 2 days of stability, no leak, nothing whatsoever, take it out and the patient goes home on the second day evening. That is what happens typically to, in this kind of scenario. And your first question was related to
using staple-aided, won't it be better?
Yeah, staple. Yeah, I think very nice, because the staples are a great tool. But only thing is staples can go in only in a certain place. So they can take, say, 2 centimeter area from the periphery of one part, but then it may not be representative of the rest of the area. So the issue of discordance, concordance came because of people doing staple from, say, only lower lobe. So, you cannot realistically imagine that we are going to fire 4 or 5 staples, because each staple costs. And every staple will keep on adding to the cost also. So cost and the inability to apply it all across will be the limitation. And therefore, stapler biopsies are not that relevant in this context. If at all I want it, of course, I will get a VAT stapler biopsies, 2 or 3 of them, and one from each, at least one from each lobe. I wouldn't do a medical thoracoscopic stapler biopsy because it doesn't really make sense, because you have to do a lot of jugaad to get that stapler in and fire it through a single or a two port also for that matter.
Correct.
So I think I would rather leave it to the vet surgeons. If I really need a bigger tissue for whatever reason, then I'll do a VATS biopsy.
Okay, great. Thank you. Again, changing gears, Dr. Parmi is coming to you. So, what is your experience with two-agent fluoridases? Do you do it? You may want to do it. When do you want to do it?
Basically, simultaneous use of two agents, we are not doing it. But yeah, in certain subset of individuals where there is a failure of fluoridesis, or we want to do a better fluoridizing action, then we may sequentially do. We have done sequential fluoridesis in certain subset of individuals, especially malignant pleural effusion patients, where especially during the early part of the career, where we were not having that talc, proper talc available at that point of time. We were using this doxycycline, tetracycline capsules and all, and even betadine 10%. Sometimes you may not procure 10% during our MD days. So these type of agents we usually give, but not now, because the talc is pretty much active as far as fluoridizing agent is concerned. If you are using it as a powderage, yeah, definitely the success rate is to the tune of around 85%.
Great. So now coming to Dr. Kaushik. Dr. Kaushik, are you there? Okay.
Yeah,
Hi. Yes. So taking it forward, what would be the dose in order of agents that you would use for double agent fluoridases, and what are the complications?
sorry, I have not used double agent fluoridesis so far. I think recently I came across double agent fluoridesis because of Dr. Ravi Mehta's case presented in NAPCON. That's when I actually came across that. But then we do use sequential double agents if there is a failure of the first agents. So I think initially we go ahead with talc. 4 grams, 4 to 5 grams of talc, and then if there is a failure, we personally have experience, large volume experience with crushing doxycycline tablets, and our yield is very, very good with doxycycline tablets. So I think we'll be publishing very soon our paper on doxycycline fluoridesis. It is much better than povidone iodine, and it is very, very comparable with, no, superior to talc as well. So that is our
And we used to use doxycycline and oxytetracycline when I was a student. We were doing it
yeah,
25 years back, much before talc was available. But
yeah,
as of now, the available data says that talc and betadine both are equivalent. Not any is better than the other. So I'm a little
correct.
surprised that,
Doxycycline
But
definitely is causing more pain, isn't it?
yeah, it
no,
causes.
no, our center experience is little. They're much comfortable, and our success rate is very, very high. So what we
Oh,
usually do is we use 10 mg per kg. We crush the doxycycline tablet, sterilize it, and then mix it with 100 ml of saline, and then infuse it into the pleural cavity, and we have very good results. So I think
actually, the trial between doxycycline and the talc was actually prematurely stopped, is what I believe.
Yes,
Probably your studies will definitely
yeah,
pave way to,
and
yeah, yeah,
because
yeah.
you are
So
crushing the doxycycline tablet rather than using the capsules. So that may be
no,
the difference.
yeah, we are crushing the doxycycline tablets, then sterilizing it, and then we are using it inside the pleural cavity.
but
Let's see.
So
We'll look forward to reading your paper surely.
yeah, yeah, sure, sure. I think we have around 25 cases now, waiting for another 10, 15 cases to publish.
But I just feel that it would be like a head-on trial would be good. You're comparing like 25 people have talc, 25 have betadine, 25
Yes,
dox.
yes. So that is what is happening. We are given it as one of the thesis to our PGs.
Wonderful,
So
right?
there is a head-on comparison which is going on here.
So this is very,
Because
very
this will be interesting, because talc is pretty expensive. Doxycycline is
Yes,
also almost dirt cheap. So I think
and also
I will look forward to reading the paper finally.
yes, 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 yes. Very soon, I think.
you feel
In another 3, 4 months.
oxytetracycline is oxytetracycline, which is a liquid. So the dose is 20 mg per kg. So if it's like 50 kg, then you give 1000 mg. And the advantage is that it's a liquid. It's a very viscous liquid. So you just
Yeah.
do it, you add saline, you add lignocaine, and you do it. And so we were doing it all the time. When I was a student, I've only done with oxytetracycline. At that time, the capsule stopped existing. So we could not,
So
yes.
yeah, so the school of thought is like if you use a powdered form I think the adherence to the pleural surface is much more than you use a liquid form where the gravity dependent drainage towards the diaphragm happens. So the success rate is more with the powdered doxycycline form. So that's what we have understood so far.
Wonderful. Waiting for the results. This is very exciting. Now, coming to Dr. Ajay, is it advisable to use negative suction for fluoroscopic fluorodesis, and why?
So in our routine practice, we don't routinely we use a negative pressure for our post-fluorodesis patients, post-thoracoscopy. So what we practice is, if we see that the post-op after the next day's X-ray, if the lung is having no complete expansion, there is no full pleural apposition, and the expansion is not complete, then we may add an suction. Upfront usual pleural suction is not usually what we have practiced, but as we go through the evidences and the papers, it shows that adding a pleural suction, negative suction post fluorosis, improves your drainage of the residual air, it improves the expansion of the lung, and improves the pleural apposition. And we know that as the pleural apposition improves, the chances of fluorodesis also improves. So there is a theoretical advantage that if we add a pleural suction, it can improve the success rate of fluorosis. But we are usually upfront don't use a pleural suction post fluorosis.
Yeah, I think even when we do an X-ray, post that, and if we see that some part of the lung is not expanded, then at that time, I think giving negative suction would really help and make sure that the pleura gets opposed so that our fluorodesis really works. So, but
But we
yes,
have found
we used to
that
regularly give negative suction. Completely agree with you, Dr. Ajay. Coming,
considerable amount of pain with the patient when we apply a suction. There is an increase in pain. That's also what we have observed. So we don't use it up.
you're very right. Exactly. Yes. Coming to Dr. Nitin, and we have some wonderful comments also from Dr. Kanamuri, which I want to really talk about. But let me just finish questions. So, coming to you, Dr. Nitin, how deep is the level of anesthesia which is needed with two-port technique? And would the patient go into apneas? And if the patient goes into apnea, then what do you really do?
Yeah, I think this is very relevant, particularly when you are doing a medical thoracoscopic interventions, whatever they are. Deeper you are, there is a higher chance of apnea. The typical story is you start with midas fentanyl, and that's mostly good, and a little bit of propofol. So mostly you don't go beyond it. But once in a while, a patient, particularly when you are using two ports, he's in little more pain, and then once in a while, people have to use ketamine, or people have to use something like inhaled isoflurane and with a mask. So, in that kind of a situation, you have to be a little careful. Once in a while, the patient with a little extra pain threshold, or a lower pain threshold can go into an apnea or a breath holding, and they have to really hang out. The anesthetists do that job. They don't really increase your anxiety, but you are constantly worried because the patient is not moving at all. And you're used to a moving lung in a medical thoracoscopy. So if it is not moving, you are really worried. Why is it not moving? So I think there they have to take over, help you. And most of the times they will, just a bit of a mask ventilation. I have rarely, or rather never intubated a single person with medical thoracoscopic lung biopsy, or for that matter, I haven't needed to do that. To convert it into a surgical like, or a double lumen, or even a single lumen intubation. Some of the experts here have used intubation. I haven't really needed this in almost most of the situations, and I have never abandoned the procedure unless until something really nasty happens.
Okay, great. Wonderful. Coming to you, Dr. Ravi Mehta. Okay, is it necessary to clamp tube before removal in a daycare fluoroscopy? That's question one. And what is the suction pressure and duration of negative suction before pulling out the tube?
The answer to the first one is no. And the answer to the second one is usually we put anywhere from -10 to -20 till the bubbling stops, which means that the air you instilled is out. And then you stop the suction and you go ahead and pull the tube. And for posterity, you do a X-ray. Or if you have a smart place with ultrasound, you do an ultrasound. So, but we will do an X-ray because sometimes old-fashioned caution still wins over new technology.
Okay, great. There are just so many questions. Actually, there are about 22 questions from the audience which are still remaining. Before I take them, I want to put very good two comments. I want to talk about them. We have our dear friend, Dr. Kanamuri Srinivas Rao. Dr. Ravi, this is a comment for you and a question, and also So he said, excellent talk by Dr. Ravi, pushing the boundaries of thoracoscopy still further. After doing visceral biopsy, instead of covering the biopsy site with parietal pleural patch, can we use surgical absorbable gel foam to cover biopsy site so that we can avoid additional procedure and reduce post-op pain?
Yes, thank you. We know each other well, so thank you for the comment and the feedback. The answer is yes, you can. Only thing is the cost increases. To the best of my knowledge, these things cost like 7K or something like that. So if something cheap, absolutely, because the surgeons use it all the time and they love to do that rather than sit and sewing inside. But otherwise, if cost is an issue, then some small piece of endogenous stuff helps more, is what we feel. Both are good options.
Okay, great. Wonderful. So, Dr. Kanamuri now is saying something, Dr. Nitin. So, Dr. Nitin, this is for you. Wonderful talk by Dr. Nitin. Use of linear IBUS through thoracoscopy is another out-of-box indication for thoracoscopy. We use IBUS to assess visceral pleural thickness during soft decortication. Another one is to target splenic lesion abutting left diaphragm, which is not accessible to image-guided biopsy. So
Hats
wonderful.
off.
I mean, hats off. I think
Great
Dr.
thinking.
Phenomenal.
This is really out of the box. It is not on the out of the box. It's out of the room, out of the country, practically. I mean, but great thinking. You can realistically apply that. We have the equipment in the same suit, and you can utilize those if you really think there is an indication. I have nothing against it as long as you have resources to have, get them together in one place.
This is again out of the box. Dr. Ravi Mehta, you have food for thought now. Okay, there's a very nice comment from Dr. Sunita Narayan Vatamparamli. She said, wow, surgical interventions by respiratory physicians. So she's very, very impressed. I'll just quickly take some questions. So there's a question from Dr. Sanket. He's asking, is it advisable to do adhesion removal via flexible thoracoscopy?
Yeah, can I take
Yes.
that? I mean, because
Actually,
it can be done.
Just one line
Yeah.
answer. Yeah.
One line answer. It can be done as long as you have another port to get in a big forceps or a blunt dissector and get rid of the adhesions effectively. Visualization, fantastic with the semi-rigid, but the forceps going through it will not be enough. So you'll need a bigger port, a second port.
And
That's it.
it's going to be a very long process when you're going to do
Absolutely.
Yes.
the
Okay.
time is going to be very long.
Okay. Then there's another question by Dr. Vishal. Whoever wants to take it. What's your experience in repair of bronchopleural fistula via medical thoracoscopy? Dr. Ravi wants to take this? Or
Yeah.
So, as we talked about, by and large, we don't really do the surgical aspect. I mean, Nitin and I will quietly say that maybe we fired some staplers inside, but we can't talk of it in as a standard strategy. So, stapler firing can be learned by pulmonologists, but usually it's in conjunction with thoracos, with surgeons, and we don't really do it on our own unless some new tiny stapler comes out, which we've been talking for a long time. Till then, it's by and large what we showed. Identify the leak, reposition a chest tube, ensure pleural approximation, look at etiology like tuberculosis, and sometimes, as we showed, out of the box stuff like trying to confirm leak using endobronchial innovative strategies and pleural supportive strategies. Having said that, the one specific thing which we showed and can be done is putting that bioglue. Please don't pull the N-butyl cyanoacrylate. That's horrible. It forms like a stone inside. You can put these bioglues, and Dr. Kanamuri may I want to do his little surgical surgical out there. Those can be done, as Nitin originally pointed out, by experienced people sparingly if the success rate is high and the feasibility allows it.
okay, great. There's another question. There's a question by Dr. Shreyami. When to decide for empyema, if to do medical thoracoscopy or just be happy with ICD? Anybody wants to take this?
I think okay. I can answer that. If is that okay?
Yeah, sure.
Yeah, so I think we showed that over there. So by and large, there's two approaches to empyema. One is that you put a chest tube, you ensure drainage, you ensure infection clearance, and you try and ensure pleural approximation. With that, you may add things like the DNAs and TPA, which has been talked about. We also are part of that Lancet discussion. And I think Dr. Nene has also talked of putting saline in there as a strategy. That's a conservative one. People like us who ultimately will have access to thoracoscopes, we find that a quick thoracoscopy done at the right time, that is in the maximally second week or early third week, can lead to a quick adhesiolisis, quick return to pleural approximation, diagnostic certainty, and at the same time expedite their discharge, and at the same time also cut the cost of hospital stay, intravenous antibiotics, and switch to oral. So for all these reasons, we go in quickly as long as there is loculated effusion and all these criteria are met. Lastly, personal bias not validated by literature, uncontrolled diabetics. That they will just go on and on. So there maybe we go in a little faster to clear the infection, control the diabetes, and get a handle on the empyema process.
Okay, great. Thank you. Now, there is a very interesting question by Dr. Kiran Vishnu. Was the biopsy forceps for applying electrocautery the insulated type, or was the monopoly cautery applied onto the reusable biopsy forceps? That is one question. And there's another question. Okay, I think this can be answered. Then we'll take the other question of Dr. Kiran Vishnu.
It's typically
the usual
typical
fluoroscopic
bipolar.
forceps. Oh, sorry. Sorry.
Yeah.
Yeah, Nitin, go ahead, please. Nitin, can you answer, please?
Yeah, I think it's a typical monopole one with insulation. So there is not the standard forceps which is used. There is nothing rocket science about it.
Okay, and even reusable biopsy forceps is fine, right?
Yes.
Okay, great.
As long as you are sterilizing it adequately.
Yes, absolutely. Wonderful. Dr. Kiran Vishnu has asked one again, an interesting question. Does the pleural patch remain at the site of visceral pleural biopsy? Do you add any additional scaffold? I think
That's a question we answered before with Dr. Kanamori.
Okay, fine. Dr. Kiran Vishnu has one more question. Dr. Nitin, what all steps did you take to manage the dyspnea with conscious sedation in the ILD patient by inducing a pneumothorax with high flow oxygen to correct periprocedural hypoxemia? Isn't there a higher risk of fire while applying cautery during the biopsy procedure mentioned?
Yeah.
You know, I'm so
I think the
excited.
standard.
Everybody's really heard the talks really well, and
I think we are maybe we are sending a wrong message. Please don't venture into hypoxemic patients. That's the first rule of business. So if you have a badly hypoxic patient, this is none of the biopsies are indicated. Treat them whatever you think is the diagnosis, rather than trying to biopsy at all. Even a transbronchial lung biopsy is dangerous in patients who are frankly hypoxemic. The 1 month mortality of a hypoxemic patient is anywhere between 12 to 15%. And that's pretty high. We can't accept that kind of a mortality after a procedure. So that is definitely a no-no. In fact, a biopsy mortality of 1 month less than 1% is most desirable. So it is true for TBLC. In a select situations, you can go with a borderline hypoxemic patient, but a frankly hypoxemic patient, you would not want to biopsy. And of course, then the cutoff point of more than 40% will come into the play. And even if you're doing a TBLC, you would not try to go above 40%. Of course, if you are doing the risk of fire is mainly related to when you are using oxygen and the cautery or the TBLC of the cryo at the same time. You are generally with cryo, the bleeding is related to yanking rather than related to actually the fire which is created by oxygen. The fire risk is relatively low with the cryo comparatively. But at the same time, using 100% oxygen is not sensible. So one has to be careful. Not going above 40% is the rule. With pleura, once again, may I request all these enthusiastic juniors not to take up hypoxemic patients for a MTLB or even a VATS. They are high-risk individuals with high mortality. Please do not do that. Use your clinical acumen and treat them.
Okay, great. This is a little bit of a medical question, but interesting. Our dear friend Dr. Sarendranath Banerjee has asked, what is the best empirical antibiotic for empyema, which is not TB, before the culture sensitivity is available? So who wants to take the medical question?
I think Dr. Nene, you only should answer it.
So basically the thing is that you want a gram-positive cover, you want an anaerobic cover, and if the patient is immunocompromised, you want a gram-negative cover. So a broad-spectrum antibiotic with anaerobic cover, so it could be piperacillin, tazobactam, okay, or otherwise you can do a simple thing like clindamycin along with amoxicillin. So basically, it just depends on what the organism is likely to be in the patient. So, okay, this question has been asked by three
I think
people.
there's no single correct answer for this. You can debate ad nauseum. There will only be a one single perfect answer for this.
There is one question which is asked by three people. We have Dr. Riddha, we have Dr. Vishal, and Dr. Bhaveja have asked the same question, of course, in different words. What is the criteria for doing VATS in empyema?
Yeah, can I take that first part of it?
Yes.
If I have a very thick visceral pleural rind, then that is more or less an absolute indication, unless until you have somebody like Ravi who can take care of everything and he can cut across and whatever, very, very talented people can do everything. Arjun, I have seen, he's brilliant with, and they are pushing the boundaries every day. So that will happen. But largely speaking, for people who are beginning, I think a big, thick visceral pleural ring more or less should go to the surgeon straight away. If I have a level 2 kind of an empyema where there are adhesions, but the visceral pleural thickening is not much, parietal pleural really doesn't matter. As long as you are able to get cross bridges out, make sure that the lung is fully expandable. You can do that with medical thorax.
Okay.
This is where your pre-procedural ultrasound scan also get to you,
Absolutely. Absolutely.
and when you can see the visceral pleural thickening and all. Yeah, the CT obviously, but real-time ultrasound, you can just decide what to do and what not to do.
I just want to say that while I'm talking to you, it's 10:35 p.m. We've been told that 1967 people are still logged in. And as I'm talking, more and more questions are coming. I think I'll just take two. We actually about 10 more are pending. We have a very interesting question by Dr. Shehbaz. What's your experience in blood anticoagulation via thoracoscopy?
Can you explain that? I mean, I didn't understand it.
It's blood installation. I think he means blood installation, Nitin. It's a blood patch. Yeah.
Yeah, I think I tried to explain that, while doing a biopsy, some bleeding occurs. Very minimal, but we leave it behind and it works like a blood patch. In a situation where, for example, expansion or air leak is not sealing after 2 or 3 days, you can use through an ICD and you can put blood patch inside. If you want to do it thoracoscopically, you are welcome, but I don't think it is necessary. You can just do it through the tube.
Correct. In certain points we've already discussed, I'll just quickly answer them. That is it advisable to do adhesion removal via flexible thoracoscopy? We've already answered this, that through rigid it's better. You want to do it through flexible, you should rather have a second port for this. This is a question which Dr. Kaushik has so nicely answered. What is the role of inhalation of antibiotics in fluorodasis? The doxycycline, crush tablet, as per Dr. Kaushik. He's found excellent results. Then other questions that we have already answered, but I'm just
antibiotics in the sense, Amita, antibiotics in the sense of fluorodacing agents or antibiotics in the sense of antibiotics?
The
Once in a while,
fluorodasis.
Fluorodasis, are you using it as fluorodasis agent? So the
doxycycline is fine, no problem. But if you are putting betadine, it has anti-infective properties also. So once in a while, if you are dealing with an infected pleura and for some reason you want to make sure that there is a position which is maintained, and you have to put something in, you could think of betadine. Very rarely I have put in antibiotics. In a very occasional situation of an infected pleura with an air leak going on, and it is a medical, it is a ruptured cyst, bronchogenic cyst, which had ruptured into the pleura, and I put in a meropenem there once in a while. But this is extremely rare. It's not for the straightforward situations. Absolutely.
Okay, this question we've already done. What are the indications of double bore thoracoscopy, which we already said that you want to just do a biopsy, one bore is enough. You want to do many procedures and the second bore will help. While I'm talking to you, more questions are coming, but I think we'll close right now. We've had a huge 2-hour session. We've answered almost every question that was asked. Our faculty has been fantastic. I mean, hats off to each of you all. I mean, respect for all the fantastic work that you do. Respect for answering every question so nicely. And huge salutes for making this very complicated topic so exciting. It was like a roller coaster ride. I love listening to both the talks by Dr. Nitin and Dr. Ravi. Our three panelists, Dr. Parmesh, Dr. Kaushik, and Dr. Ajay, were absolutely phenomenal. And hats off to our audience for asking us so many questions. We got like 45 plus questions. And a huge big thank you to Ashish from CIPLA and entire team CIPLA for making sure that they are academic partners and they're helping us percolate knowledge everywhere. And thank you to Dr. Mehul Thakkar for always being there and making us all the wonderful questions, etc. I think maybe we can end with this. Hi, Mehul. Good to see you. Okay, thank you so much, everybody.
Thank you, Dr. Nay. Thank you, everybody. Good
Thank
night.
you. Bye.
Night. Night.
Hi.
Thank you, ma'am. Thank you, IAB. Thank you. Good night.
Okay, Dr. Parmez, you can give us a quick welcome for BronchoCon.
Yeah, definitely. Means I have put up a flyer actually along with my this thing. Anyway, I take this opportunity to thank IAB first of all letting us do the BronchoCon 2024, and I welcome each and everyone, IAB members and non-IAB members, PGs, and everyone from freshers to the veterans to Cochin in May 2024 from 24th to 26th. And we are actually moving a bit more than what we have done in Mumbai. We are adding on few more workshops and some exciting lectures in a beautiful venue at Le Meridian, Cochin. So I invite you all to Cochin, and hopefully we will meet you all at Cochin on 24th, 25th, and 26th of May. Thank you.
Chalo Kochi,
100%
everybody.
behind you, Dr.
Welcome to Kerala.
Absolutely.
Yes. Okay, thank you.
Bye.
Yes.
Thank
Good
you.
night, everybody. Thank you so much.
Thank you, ma'am. Thank you all. Bye.
Bye-bye.